department, family birthing place and hospital OB.
So I'm Amy, I'm the Director of Family Birth in the Fourth Trimester Center. And today with me, I have Julie Harwell, who's been a nurse here for how long?
14 years.
14 years. And she works in the Fourth Trimester Center as one of our postpartum nurses. So a little background about family birth here at KVH. When the new hospital, this one now, was built in 1964, OB services was part of that. I do believe there was some OB services in the older building as well, but not a lot of record.
I've heard
of that from what I've heard. But OB has been here since the building of this building. In 1997, we did a big remodel to the family birth department. Originally, it only had 3 rooms, and what are our 2 triage rooms now, which are very small, were our labor rooms. And then 2 OR rooms that they did all the deliveries in. So once they went to the delivery room, then they went to one of the 3 rooms, and it was shared rooms, and then all 3 rooms shared one bathroom. See how small it was. So in the 1997 remodel, we took out one of our ORs, so we still have 1 OR in there, and added 3 more rooms to the unit. In 2017 is when we did a big shift with lactation. So that's when we had our first certified lactation consultant here at KVH. I don't know the exact time frame, but in 2019 to 22, we started and finished our second big remodel, where we refreshed all our rooms. We added oxygen to all of our labor rooms so that we could have panda warmers in there. And so that was a big project that we did during that time. Also during that time in 2021 is when we established the Fourth Trimester Center. And then in 2022 is when we had our big loss of our OBGYNs, and had a big transition through that. Once that all kind of took place in 2023, our staffing was 1 family practice OB provider, 1 midwife, and 1 nurse practitioner. And we were subsidizing with locums. 23, 25 through 25 is when we went to the OBHG model. And that process was established. And then by the end of 2024, I think December, all our OBHG providers were on board and are still here. 2024 is also when I took over as director. So Stacy Botten switched over to informatics, and I came from clinical education and went over to family birth, but I have been an OB nurse for my whole career. So going on 20 years. I know the area well.
We've had the same lactation consultant all 8 years.
Yes, correct.
Which is amazing.
Yep. And the same nurses in the Fourth Trimester Center since it
And
opened.
Julie as well has been.
Yep. Just a little overview of some of our providers here. Our OBHG providers, if you haven't met them before, is Dr. Tagavia, Dr. McSorley, and Dr. Johns, who come in rotation. And do not only do they do OBGYN coverage, but they also do surgery while they're here and do on call. And then also our family practice doctors and pediatricians. For family birth staffing, you have me, and I oversee the nursing staff, and our new role, divisional coordinators, which used to be our CNAs. So we've switched to a different model of unit secretary based work, so then I oversee them, and as well as the lactation consultant. How our staffing works is that we have 3 nurses on 24 hours a day, 7 days a week. This is a new model for us. We were doing 2 for quite a while up until the last few months. We also have a divisional coordinator Monday through Saturday, 7 to 1900. Our lactation consultant is on 4 days a week. She typically works 10-hour days, but she sometimes fluctuates her schedule to meet the needs of patients as well. And then we have our 4th trimester nurses that are covering that department 7 days a week during business hours. We also have an OBGYN coverage 24/7, anesthesia coverage 24/7, and then a management coverage through me 24/7. A couple months ago, we asked all of us directors to come up with vision statements for our departments. And so, not only myself, but also the staff kind of came up with what we see as our vision statement for family birth. So do you want me to read over it, or you guys just want to read it?
You do you.
Okay, well, you guys can read over it and ask and see if you have any questions.
Like the acknowledgement and the last bullet point, the last statement there that about the lasting impression, that's so true. And such an imprint on people's minds and hearts, what happens in the family birthplace. So
Mhm.
it's
Absolutely. I feel like whether someone has a good experience or a bad experience really dictates whether they stay with KBH long-term or whether they go other places. So,
or if they had a, an unfortunate experience, but received really compassionate care, that's a huge impression as well. Good one.
So a little bit more in depth of our department and what we offer. So we have 6 rooms, 3 are deemed official labor rooms and 3 are smaller postpartum rooms, but you know, in the moments we are busy, we'll use all rooms for everything. We also have 2 triage rooms and we have 1 OR and then 2 nursery bays that we will use to stabilize babies if they need a little extra help. Otherwise, they just room in with their parents. We are a level 1 facility, and some of the things we offer are antepartum care, which includes scheduled NSTs, which is non-stress tests for pregnant patients, triage visits for anything that comes up during their pregnancy that they need immediate help with. We also do IV infusions, which we cover from SOP services for pregnant patients in the last year. We do preterm care, we do labor and delivery care, not only for women's health, but also for basalt. And then we also take midwife transfers from the community. We do cesarean deliveries. We offer obstetric analgesia and anesthesia, so epidurals, or spinal. We do postpartum care. We do level 1 newborn care, which means we will deliver babies greater than 35 weeks. If there's anyone less than 35 weeks, then we will stabilize and transport them elsewhere, which we are very good at. We do high risk pregnancy care up to a limit. We have things that we can do here and then things that we will transfer patients out if needed to other places with higher level of care. And then we have the 4th trimester support that Julie is going to go into. But it is a free care for the entire community. So they don't have to deliver here at KBH. They can have delivered at another facility and then come here for that postpartum and lactation support. Like I said, it's a free service, so no insurance, no, anyone just walks in and they get the care that they want. Within the 4th trimester, we also have some support groups and community collaborations that Julie can touch more on. Okay.
Can I ask you a couple of questions before we hand off?
Yeah.
So for the free service for people that did not deliver here, how do we get the word out to them that this exists?
Well, in a variety of ways, but sometimes their providers will a common way that they get to us is that they're delivering, let's say at Swedish Issaquah, and then when they're being discharged, the hospital wants them to make appointments, follow-up appointments for their babies, and so then they will call, if they're coming back to Ellensburg, they'll call KVH Peds often, and then KVH Peds will say, we can't get you in for that first appointment, but we can see you at 2 weeks, call the 4th trimester center. So then when they call the 4th trimester center, we can get the baby in for that first weight and color check, which we want to do usually within 1 to 2 days of discharge from the hospital. So we can do that and we'll do a whole 4th trimester visit with mom and baby. So that's a common way that they get to us. We also, through the 4th trimester center, we do the birth and family education through 4th trimester. And we have people who find our classes online that aren't going to be delivering here at KVH, but they come to us for their childbirth education classes. And we talk, we're in the fourth trimester center. We talk about the fourth trimester center. And most of those people then will ask their providers to refer them back to the fourth trimester center after they've delivered, wherever they delivered. And they also often will say, Pat, just recently, they intend to deliver someplace else. They take our classes, they go on the tour, and they end up delivering here, so, because it's a good place to be, right? But they know that because they're here and they're seeing it and they're asking questions. So it's a lot of that.
A lot of also word of mouth, moms talking to different moms, social media, and they do a really good job of getting word out amongst, mom groups.
And you also had said that occasionally we have a baby that has to be transported. What percentage of that is in this community?
I don't know exact number. It's not common. Because we only take a certain amount of risk value here. Most of our babies get to stay here, but we do have things where someone calls 911 on 990, like it happened the other week, and we had 23-week twins that we had to ship out and deliver. So we do get some of that as well, of people being in the area, especially in the summer. They went camping, they come in, they're, not that age and we have to send them out. But it's a small percentage. Dr. Thomas, do you know percentages?
I don't have a number off the top of my head, but
It
it was like 3%
Yeah.
when I had looked into it.
Yeah, it's not a large
Yeah.
one.
I had explored it before our baby was born too, and
Yeah.
we got to be one of those that. And just from going through it, our hospital was such an amazing job working through those two, and in connection with the receiving facilities and life flight teams. It's just amazing to go through that firsthand and see how a network works together.
Yeah,
Yeah,
it's important to emphasize that means the system works. The
Yes.
role of a critical access hospital is to deliver that immediate care that's needed and then help triage and identify the appropriate resources for definitive care. So
Right.
Excellent.
Yeah, and we have a great relationship with Lifelight, so if we have any acknowledgement ahead of time, that's the situation. We can call them and they'll be here and they come with the whole NICU team. And so even when we don't know when they come over, they bring their own specialists and then continue, do that care while they're in the transfer route.
So Life Flight has a specific team based on what they know they're flying, if they get advance notice.
Yep.
That's
Yep.
nice.
So they'll send a NICU nurse and their own respiratory therapist and any other specialty needs they need.
Thank you.
Yeah. Do you want to talk a little bit more about those?
Sure, I don't know how much you want to know, but fourth trimester center, we started it almost 4 years ago. 4 years ago, I think in August, September. And when I look back at where we've come so far in 4 years, but it's been sort of this gradual add-on. We really are a resource center. So we want people to feel, new families to feel welcome to kind of stop with us if they need resources of any kind. And so when people come in, when moms and babies and dads and older siblings come in, we assess moms, we do a physical assessment initially, we do the weight and color checks for the babies. And a big part of what we work on in that first visit is feeding, and if there's any feeding issues. Because if there's feeding issues, there's going to be other issues too. So if we can get on top of feeding, we can kind of get past a lot of that early stuff. But we also spend a significant amount of time talking about maternal mental health, and that's a big part of what we add. I think that we have the time to add that other clinic visits maybe can't focus quite as much time on. And it's a really comfortable, you're in an office, it's pretty comfortable, and people tend to talk about how they're feeling. So this is a new thing for me as a nurse. I was always a labor nurse, but to actually spend time just talking with people and really hearing how people are doing in the postpartum period lets me know that all the statistics that we're hearing about how well people are not is true. Nobody's sailing through postpartum. Not a single person in our county just kind of thinks, this is wonderful. I love this so much. Nothing's wrong. So when you ask them and you sit with them, you're hearing this stuff. We have the support groups that we started. We're really proud of those because they are having a huge effect, a huge impact. And those support groups are growing because people are coming in and by word of mouth, they're telling other people. And we have some people in our support groups and our postpartum park ramble that we do every Tuesday at a local park. We get together and we just get out and walk and just talk about how things are going. But all these ways that we're trying to make connections between new families in the community is really, I think is really having a positive impact. And some of the people in those groups are now, I consider them kind of unofficial ambassadors for the Fourth Trimester Center. They walk around with our postpartum park rat cards on their person, and anytime they see moms and babies out in the community, when they're out with theirs, they're saying, come to our park ramble, come to one of the supports. And so it's just kind of exponentially growing the participation because it's having such a positive impact on the families. The other thing I would like to say is that by doing this, providing this complete access to people, they don't have to have insurance, there's no fee involved. They can, it really, I hear so many positive things about KVH because they've gotten introduced to this program and they are so appreciative of the fact that they have this. And their mothers, the grandmas are saying, we never had anything like this. This is amazing. I wish we would have had something like this. And so it's had a real ripple effect, I think, from the people that we've seen, and you see it kind of ripple out. So
I can attest too, because I have a huge age difference in my kids, that I had my last child who's 3 here and went to the Fourth Trimester Center. Compared to my 16-year-old, those services weren't around. I had to figure it out. I had to figure out how to, function and cope and breastfeed. And so to have the support there that you can go to is just amazing.
Makes me want to have another kid. Right.
Yep. And then in addition to the support groups, then you have all the moms who now have a community of people that understand that are all making their own groups, and they have their own chats going and they're getting together and, so then they don't feel so alone.
it's a big mom group. We also do the grief and loss support, which I think is a big piece that was missing. That's a goal is to do more with that, but we took on the responsibility of making contact with everybody who's had at least making contact with every mother who's had a pregnancy loss, especially early pregnancy loss, because a lot of times that doesn't happen by way of the clinic. It happens, women will be bleeding, they know they're pregnant or think they're pregnant, they come into the loss of the pregnancy is diagnosed and they're sent home, and then that's kind of what they get, right? Because it was early. And so what we try to do is, it took us over a year to get it set up so that we could get flagged when those people did come in. But now we have it in place. We use the AdaptX program, so we can see when people have come in with a possible pregnancy loss, and then I can follow through. I can do chart review and follow through what happened. And then for the people who truly had a loss, then I could at least call them, make contact with them, and let them know that we do have some resources for grief and for support. And really just letting them know that KVH is acknowledging that they've had a loss of a pregnancy, and that we recognize that that's a significant thing.
Could you say a little more, please, about what those resources are?
Well, we work a lot with community resources and online resources. One group that we work with a lot is Perinatal Support Washington, or PSWA. And then their bigger organization is Postpartum Support International. So they have a lot of mental health resources. They're a huge resource for us because they have a lot of online resources, but also local referrals. So because there just aren't enough mental health providers in any community, but certainly not in our community for maternal mental health, those online resources are amazing. They're really important. So we use a lot of their resources, and we connect. So we can, if somebody comes into the office, let's say, and is having a really hard time with postpartum depression, anxiety, postpartum grief, or pregnancy loss grief, if it's something that they need more, it does seem like they maybe could benefit from talk therapy or talking with a counselor. We can make that phone call while they're in my office if they want to. We can connect with PS Washington, and then they can get the information and they can find an online provider that will be covered by their insurance, that particular patient's insurance. So we really rely on them a lot for resources. So.
Thank you.
And on the clinical side of it, whenever we have a loss in family birth, we have specialty services to make special packets for the parents. Rosique, our amazing lactation consultant that does so much of this work, will come in and take pictures of the newborns for the family. And so we really try to, give them services about grief support as well, on the clinical side as well, when they are with us during that time.
And Commissioner Davis joined us online, and he asked a question about the dad's role in the fourth trimester program. Is there a role that the dad plays in this process?
Yeah, so we hope that the dads come to those first appointments, and I would say 85% of them, 90% of them do. The ones, sometimes the dads don't come if they have lots of older children, and so they'll stay home with the older kids and mom will come in new baby. But in general, dads come in for that appointment too. And we talk to dads at this, I mean, we acknowledge that there's such a thing as postpartum depression and anxiety for fathers too. The statistics are up to 10% of men will tell us they're having some symptoms of postpartum depression. That probably means that it's more than that. But we acknowledge that this is an adjustment for the entire family, and we want them to know that. And I always ask them, I'm sure Katie does too, do you have any questions about what's happening with mom or the baby? You know, and they often have questions that mom doesn't have, or that they've noticed. So, and they're a tremendous help with breastfeeding too. And so if we can have a dad that's in there that's helping mom with breastfeeding as we're showing her, he's watching too, that's a success for them. So,
So just to leave a little glimmer of what we do or how many deliveries we have in family birth. Our numbers used to be kind of falling just in above the 300 range. And then you can kind of see that in 2022, we had 319. And then you see a nice drop in 2023 and 2024 of when we had our changeover in all our providers. And we are slowly getting back up there. In 2025, so far as of today, I think is the last time I looked at it, we had 142 deliveries so far. And I did all the lovely math. And if we're on that same trajectory that we've had for the first part of this year, we should have over 300 deliveries for this year. Every month is different. We have some months that are slower than others. It's just kind of how it always goes in the OB world, where you'll have nothing and then all of a sudden you're completely full, and then the next day you're nothing and then completely full. So it's hard to kind of gauge on average, but it's close to about a baby a day. Do the math. Currently for July, as of today, we've had 26 babies. We still have quite a little bit of the month left and quite a few people still out there. So we'll most likely hit 30 or above for this month. But in addition to delivering babies, we do so much more in family birth. So our unit is the only unit that does outpatient visits like non-stress tests or triage visits or infusions for the whole county. We're it. And so not only do we get women's health patients, so let's say a patient is 32 weeks pregnant and she has some risk factors that are making her high risk. So let's say her blood pressure is high. The physicians go by their guidelines and say, okay, now they need to have non-stress tests visits 3 times a week. So then they will come over to us and we monitor the baby 3 times a week for them. If anything of concern comes up, then we let the doctors know, but we communicate with them with every visit. So we do a lot of those as kind of the community gets more sicker and not as well. We tend to see more outpatient visits. We weren't really tracking the numbers up until recently. So April to March 2025, there was 789 visits that we saw in some outpatient fashion. And since then, now that we're tracking them, May, we had 87, June, we had 94. So far in July, we've had 85. And if we keep these numbers up, we'll see over 1,100 patients in the year for outpatient visits. Like I said, it's not just women's health. Silver Salt will send their patients over to us as well, CHCW. So because we're the only ones doing these kind of visits, we get all of them. So even in our times where we may not necessarily be having delivering babies, we will have days where we have a scheduled outpatient visit every hour of the day. So we're doing that work as well. And then in addition to that, it's good to note that we're seeing less and less low risk deliveries without any complications. As you can see, from May to September, we have about 120 OB patients on the books just for women's health. And 43% of those are high risk for one reason or another. Of those 120 so far, 16% has risked out to other facilities that they've had to transfer their care. That number can change as we get farther into pregnancies and more complications come up and who gets transferred out versus who stays. But hence why we have changed our staffing, and family birth is that everyone is, more complicated. And so they need more one-on-one care. And the guidelines we follow for staffing, will deem whether they're low risk or high risk and how they need to be ratioed with nurses. So.
For those 16% that are high risk, you want them to go to another facility delivered. Are you also like preparing or having them at somewhere on your list that even though they're planning to go to Issaquah or whatever,
Yes.
might be coming in
Yeah.
here between these weeks or something?
We do. So every week, actually, myself and the women's health providers and their staff, we get on Zoom every week and we have a list of all of their patients that they know of, even ones that might be transferring to them from Compass or Basalt. And we talk about every single one of them. So we keep every single person on the list, whether or not they had a miscarriage or they get transferred. And so we do have them on our radar because they do sometimes come in. They don't make it over to where they're supposed to go. And we just had one last week where she's planning to deliver at UW. She came in having an attack from preeclampsia, and we had to stabilize her here and then send her over to UW. So we do know that they are there around and they can definitely come to us at any point.
I mean, in addition to the deliveries, which we count a lot, I think it also deserves mention that there's a lot of work that goes into the care before the delivery and after the delivery. So I would imagine that on average, we're probably racking up about almost four patient days between mother and baby for every delivery on that list.
Yeah.
So this is a department that is working hard day in and day out, even on the days when the babies aren't actually arriving.
Yes,
That's a good point.
agreed.
Along those lines, I wanted to ask, OB has a very high fixed cost because obviously you don't know when the babies are going to arrive.
Right.
Currently, say we're 250, 300 a year. How high can we go with the current fixed cost before, kind of just answer the question, to make it sound like it's not just about the baby arriving, it's before and after and stuff. What patient load could we take under the same structure we have before we'd have to grow to that next step?
We would have, we have a little bit of wiggle room, but anywhere past, I would say 400 deliveries.
So not a lot of head.
No,
Yeah.
we would need more RN staff because labor patients are one-to-one with nurses because you're not just taking care of the mom, you're taking care of the baby. And so if we have, 2 labors and a mom that has delivered, that takes 3 nurses right there. Because the 2 that are in labor have to be one-on-one with their patients. So it would require extra staffing for sure and growth. I do think it's possible.
It'd be a good problem to have. I mean,
Yes.
it's that
Yeah.
they're hearing what we're doing and they're responding to it.
Right.
So that's positive. And I also wanted to acknowledge Liz a little while ago had a comment online and she just thanked you for doing the care for loss, acknowledging that stuff. So thanks for your comment, Liz.
She also had a question about staffing. Are you staffed now? Currently now?
Oh,
We saw positions posted.
Yes, so with our change and going from 2 nurses to 3, we have had staffing openings. A lot of our nurses that filled the extra nurse on days came from nights, and so then it's a cascade, and then we have openings on nights. So we've had a few openings on nights that we've been filling with travelers. We have 2 of our full-time positions filled. One's started training a couple weeks ago. The next one's coming soon. We have a part-time position also filled. And then our last full-time position, actually, we just gave most of the FTE to one of our per diems that wants to actually take an FTE. And then so it just leaves us with 2 shifts a month on nights that we are working on filled.
And we changed it. We reduced TNAs, added more RNs.
Yes, yeah, so we're adding, we're not losing anyone, we're just adding people.
And restructured the type of staff caring.
Yeah.
Thank you.
So some of our accomplishments to note is creating our new staffing model. It's not always easy to make those kinds of changes. And so that's been a big project that Debbie has been working on with us to make sure that we are we have the staff that we really need to function in family birth. So before the 3 nurses, we had 2 nurses and a CNA, and our CNAs have moved to a divisional coordinator, so secretarial type role. Because really in the times where we're really busy, we need the nursing staff overseeing. We love the work and support they give us, but that's really where we need to go. And it ended up being a lot of times that I was there all night long and worked all day, just try to help support them, because we need nurses to take care of them when they come in, and they come, labor patients come in at any point of the day. We never know when they're gonna show up. So that's been a big project that we've been working on. Another big accomplishment is having our full staff of providers. And it's just really been a great thing for the staff, because for many years they were dealing with locums, which we had great locums, but you couldn't really get anywhere with progress or establish new procedures or standard work, because people were in and out and weren't there permanently. They didn't really have a stakehold in doing those things here because they weren't working for us. So it's been really great to have solid providers again that everyone is getting to know, and they know how they practice, and we can make changes to better the unit. So that's been a good thing for us. We also have 3 nurses that we certified to teach our fetal monitoring course. So as many people know, it's sometimes really hard to find specialty courses to do all your recertifications around. And fetal monitoring was one of them through A1. So we just brought it upon ourselves to teach ourselves how to do it so we could teach the staff. So myself and Jennifer Crane, who works in clinical education, and Stacy Button, who was the previous director, are all certified, and we teach those fetal monitoring classes for our staff. We also had a community baby shower event. So it started out as how can we connect the community? How can we let them know that we have new providers here, and the services that we're offering, things like 4th trimester center, more access at the clinics. And so we started out with, do we have an open house? And then it kind of turned into this, but we really want the community to know what all the services out in the community are for families. So what it grew into was not only just a visit, an open house for KBH, but for all of our community providers as well. So we had Valley Psychological Services there. We had Dino Discovery, which is one of the new kids play centers in town. We had CHCW there. So as many community members that we could get there in one room, so that when the community came to see us, they could ask questions to all of the members of all the connections that are out there, so they could be aware of, what services they have available to them. So it was a great event, and I hope to do it every year. And I think it's just really good for our community. 4th trimester has also been working under a grant from PSWA for mental health, and that's where all these support groups were established. So Rosika has 3 support groups out there. One is an art class. Is that the
Yes. We're not doing that anymore though. It's finished. It
It's
was
done?
completed, yeah.
Okay.
Well, when the PSWA grant went away, we had the conversations of how are we going to keep these support groups going. And actually the 4th trimester was approached by Paragee, which is a grant group that has someone local here in Ellisburg that had heard about the 4th trimester center and came to them asking if they could donate money. So they just donated $25,000 to them. And so that's going to help keep a lot of their work that they were doing on mental health support going until we have plans for our next grant. So that's a great thing happening. Recent patient success stories. So I mentioned a little bit briefly about, I just want to give props to my team, because we don't always get big emergencies to come in, but when we do, we work really hard to prepare for them. We do tons of drilling through the year. So even if we don't get to practice our resuscitation skills often, we definitely practice it a lot. So we have those moments where we, do have something that we have to face that we're ready for it. So recently, a couple weeks ago, I got a call about 5:30 that there was a patient coming in that wasn't a patient here, 22 and a half weeks. So normal pregnancy goes to 40, so about halfway through. Coming in labor. So I came in and luckily it was right at change of shifts, so we had both shifts there. All day shifts stayed over till probably 11 o'clock at night. But we then proceeded to deliver almost 23-week twins who were about 1 pound each. And we worked diligently for 2 hours while we were waiting for the teams because there was some weather issues to come over with the NICU team, so much so that I just stood there and breathed for a baby for 2 hours. And both those babies left alive, which is a huge deal for us. Neither one of them ended up making it, but not from anything that we couldn't provide. They just were so small. And so premature. But just the fact that we could come together in a really small unit and somehow have enough staff to man 2 coat teams for a baby and enough staff for the mom, in addition to the labor patient and other patients we already had in the unit, is pretty profound. We also have started recently doing Team Birth, which is a Washington collaborative that really focuses on getting the patients involved in their own decision making. So a lot of the times we're already doing that, we just end up leaving the patients out of that conversation, right? So the doctors have ideas, they briefly talk to the patients and they come to the nurses and talk together, and then the nurses go and relay that information to the patients. And then if they have questions, and then back and forth with how we go. So lots of studies that say that the better way to do it is to actually just have those conversations with the patient in the at the bedside. So Teen Birth has been an initiative through Washington to do just that. And so we joined that collaborative just this past year. And so what it looks like is, instead of having those individual conversations, we are diligent about having a huddle with the patient anytime there's a change in care or when they first come in. That includes the nurse and the support people and the patient and the provider to be like, this is what our plan is. This is what we're thinking. Or do you agree with this plan? Are you okay with how things are moving forward? And it's been a really great, positive experience. I think it's made us adjust how we are doing things, but it also let us know that we are doing a lot of those things already. We're just being more intentional about it. So part of that process was we survey our patients pre teen birth and then post teen birth, and in the surveys there's an area for them to write comments. And so I just wanted to share some of the comments that we see from our patients post teen birth. So I don't think I've seen a negative comment so far. Everything has been very positive. And it's just a nice reminder that the work we are doing is making a difference and that people are having the experiences that we hope that they're having. Trust me, I think if people have negative things to say, they're not afraid to say them. Especially in an anonymous paper that we don't know who the patient is. So just something profound to note as well. Okay, things we do in our department for quality. Like I said, we do our quarterly drills, maternal and fetal, and then we will add to those as well as we have events come up. So let's say we had a stat emergency C-section that the OR crew didn't make it into, and staff felt like, oh, we need reminders on that. Then we'll add in specific drills throughout the year, kind of on different subjects that we feel like we need more practice on. And then Teen Birth, like I talked about, we have our Blue Band initiative going on, which is a protocol on how to deal with preeclampsia with patients. So what the Blue Band does is alerts other facilities or caretakers like EMS or the ER that this person is at risk for preeclampsia during her pregnancy. So at any point during the pregnancy, it could be in the office, it could be in the hospital. If they meet the requirements to be concerned about high blood pressures, they will get blue banded, they get sent home, a blood pressure cuff to monitor for themselves. And then it's just a way to know, because
a blood pressure of 140 or 90, the ED might not be a big deal for someone else, but it's a big deal for us in OB. So it's a way to alert everyone that this is a concern and they should be paying attention to it because a lot of it was being missed.
Is that a 6-week program or 8 weeks?
Yeah, it goes up to 6 weeks postpartum. So they'll wear it up to 6 weeks postpartum. We also have our QBL quality improvement. So a few years ago, when I was working in the unit, Stacy asked me to work on this. So for a long, the standard was to do estimated blood loss, which is they just kind of look at the bag and eyeball. It looks about like 200. Clearly, we have decided that that's not a good way to practice. And so we went to the quantitative blood loss practice. So in every room, we have a scale. We have lists of what every single one of our equipment weighs dry. And then our nurses will weigh all of the equipment we use. The doctors will look at our bags before and after delivery to see how much the blood loss was. And then we'll calculate the blood loss at birth and then 1 hour postpartum and 3 hours postpartum to get an idea of how much blood loss. And at any point they go past the threshold. So more than 500 for a vaginal delivery, more than 1,000 for a C-section, then we have protocols to call the physicians and let them know so that we can treat it before it gets too bad. In addition, we're just starting the process of working with OBHG on more quality projects. So they are going to come alongside us, sounded like in September, and help us kind of streamline what other quality things we should be focusing on that's OB specific. And so more to come with that. In addition to that, they're also going to be helping with us with our OB-ED model, which I'll go into a little bit more on another slide.
Let's ask what's OBHG.
So they're our provider group that we have our obstetricians through. So we have a relationship with them.
Was it OB hospital group?
Mhm.
Yes.
So overcoming challenges, one little, when I'm going to use an example is when I came into this role, we started to look at how we functioned as OB triage. Long story short, I started to look at it because we wanted to get away from nurses doing their own charges instead of having charge permit deal with them. And it kind of opened up this can of worms with our triage. We discovered that we haven't been coding them right as an encounter type. We used to code them as observation, but they don't technically meet those requirements of observation because most of our patients don't come in for greater than 4 hours. They're come in, they get checked for whatever reason, they either go or they stay. So we worked on that and making sure that we were coding them appropriately. And also through that process, looked at kind of what the standard is in other facilities. And most other facilities are going to what is called an OB-ED model. So we're a subset of the emergency department. A lot of the work that we do down in OB can be done over in the ED, but we're not charging them or coding them the same way. So we're trying to streamline it so that we are similar. So we're just kind of a subset of ED. It's just an OB specific area for these patients to come. It helps bring in more revenue for these visits, as well as our current model is our nurses really do most of the care with these patients. They do all the hands-on stuff and just have a conversation with the providers over the phone. They sign off on stuff unless they're preterm, then they have to come in. But most of the patients don't ever get seen by a provider. So it's also changing that model of every single patient should be seen by a provider, whether it's an easy, they are there, their water broke and they're moving on. They should be. I mean, that's what they're paid for, is to see a provider and not just a nurse. And so we're also working with OBHG to figure out all the technicalities of that and all the rules and regulations before we move forward with that. Other notable changes in our department is new providers, new director. There's been a lot of change with that, but everyone has taken it really well. Changing our triage model, our staffing model, and then hopefully some new monitoring equipment coming down the turnpike at some point. So we're working on that currently as well. What's to come? We thought it was good to note that we just want to stay open at this point.
I think I can talk about my whole team in that they absolutely love what they do. They love, every single person loves helping moms and going through those hard moments with them and being a part of that really important moment in their life. And we just really want to still be here and be able to provide those services to our community. In addition to that, we also talk a lot about how we can be more profitable, how we can have more deliveries. What does that look like? Does that involve bringing maternal fetal medicine service somehow to Kittitas County? Does that involve looking at our level of NICU availability? One of the biggest things I think we hear often in this community is that people choose to go to a different facility because we don't have a NICU. They like that knowing that they're not going to get separated from their baby. And so that's a big deterrent. So just looking at those things of how can we give more to this community, be profitable in what we do, and provide these services that the community really needs. Because the closest NICU is Yakima, and they're very often closed. They're full. They don't have, so they end up transferring people out themselves, even if you showed up at their door. And then beyond that, the other NICUs that are around are at Swedish Issaquah and Tri-Cities and Spokane. So there's a huge need in this area for those type of services. So we hope to one day be able to fix that. The last thing is when I was thinking about a closing takeaway, I was like, how do you put into words everything we do in our unit? And so as best as I could explain, I came up with this, that in rural communities or communities all around really, the OB department is more than just a unit in the hospital. It is the beating heart of hope, resilience, and new beginnings. Every birth is a testament to the dedication of caregivers who show up day and night, often with limited resources, but limitless compassion. Our work ensures that every family is met with skilled hands, kind hearts, and the promise that every new life matters. Our commitment doesn't just deliver babies, it delivers a stronger, healthier future for the entire community. That's good.
Yeah, thank you. Anybody have any questions? Thank you for the presentation tonight. We really appreciate it. Very informative.
Absolutely.
And you are free to head out if you don't want to sit through a fun meeting.
Thank you, I appreciate it.
I've just one comment to remember to vote.
Oh, yeah.
This August 5th ballot, vote and get it into the ballot box. Two steps process there. Thank you, Julie.
Yeah.
Thank you, Amy.